Okay, so the three topics that we're talking about tonight, advanced care planning, palliative care and voluntary assisted dying, are quite separate topics but yet related. So they have different purposes, they have different legislative requirements and different expectations of health professionals. But they're topics that are linked because they're part of a continuum of care, I guess, as a person comes to the end of their life. And they, each of them are about, promoting autonomy and providing the best experience of end-of-life care that that a patient can have that's in line with their wishes. So I guess we can think about them as a suite of conversations that we may have with our patients when they're thinking about or worrying about or preparing for their future. So tonight the topics around advanced care planning that I'm going to go over are: what is advanced care planning? Why is it important? Who can make an advanced care directive? And the three components of advanced care planning. So we kind of use the ACP of advanced care planning as a mnemonic. So A stands for appoint a medical treatment decision maker, C stands for communicate your preferences and values, and P stands for put it on paper. Advanced care planning is a process, and I think process is a really important word. It's not a one-off thing, it's an iterative process that we build on over time. It's a process of planning for future healthcare and personal care, whereby the person makes their values, beliefs and preferences known in order that if there comes a time when that person can no longer make or communicate their own decisions due to a lack of capacity, there is a guide for the health professionals who are caring for them and for their loved ones about what they would want in that situation. I like to sort of envisage advanced care planning in this way. Advanced care planning is this umbrella that involves reflecting, thinking, talking, finding out more information. So thinking about what's most important to you in terms of your healthcare, talking to your health professionals, talking to your loved ones about that, finding out more information about what might be ahead for you in order that you can make an informed decision. And out of that process might fall one of these things. So you might choose to formally appoint a medical treatment decision maker or a support person, and you might choose to make an advanced care directive, and that advanced care directive can be comprised of an instructional directive and or a values directive. But you might stop at this point here. So, it's still advanced care planning even if you don't do anything formal or write that down, as long as you feel that, your family understand what your needs are in order to be able to represent you faithfully at a time when you can't speak for yourself. You don't actually have to go through the formal process, but certainly by putting things in writing, it can make it easier for people in a time of crisis, to have those conversations with health professionals. So there's a lot of benefits to advanced care planning. I think it's important to recognise that lots of families don't talk about these things. So people might say that, my daughter knows what I want or my husband knows what I want, but the reality is that unless you've had a conversation, you're guessing what somebody else wants, and research has shown that you've got a 50-50 chance of getting it right. So it's really important to have those conversations. And when advanced care planning is implemented well, we find that it improves the experience of end of life for patients. it reduces stress and anxiety in their family and loved ones, because they feel confident that their loved one is receiving care that's in line with their express values and preferred outcomes. It decreases the use of invasive and intensive treatments at the end of life. It decreases transfers from residential aged care to hospital at the end of life. So it has lots of benefits. It promotes the person's autonomy, and it defines quality of life according to the person's own definition. So it's their view of what is an appropriate quality of life, and it avoids prolonged suffering. It also increases the likelihood that someone will die in their preferred place. So anyone with capacity to undertake the process, including children, can make an advanced care directive. So that's a recent change. It used to be only anyone over the age of 18, but the tests for capacity in children are higher and have to be done by someone who has expertise in child psychology, or a medical practitioner with expertise in child development. But anyone can make an advanced care directive, but it's obviously particularly relevant for people who are living with a life-limiting illness. It's also very relevant to any patient over the age of 80 who's admitted to hospital from the community for a medical or surgical condition, because we know from data that those people are at an increased risk of dying within the next 12 months. It's appropriate for anyone who you would answer no to the question, would I be surprised if this person died within the next 12 months? Are people familiar with the surprise question? It's actually quite a good predictor of 12-month mortality when medical practitioners review their patient, and would they be surprised if this patient died within the next 12 months is quite a good predictor of the mortality for that group. And it's obviously really important for people who feel strongly about certain treatments. So for example, Jehovah's Witness, who might use an advanced care directive to refuse certain treatment. So we talk about someone with decision-making capacity, and you're probably aware that, in Victoria we recognise that people have decision-making capacity unless there's evidence to the contrary. So unless you have a reason to think that someone doesn't have decision-making capacity, you assume that they do. But if you look at the Medical Treatment Planning and Decisions Act, decision-making capacity is defined in 4 parts. So someone has to be able to understand the information that's relevant to the decision that needs to be made. They have to be able to retain that information for long enough to be able to make the decision. They have to be able to weigh up the options that are available to them, and they have to be able to communicate that decision in some way, including by gesture or other means. So when we talk about medical treatment, again, in terms of the Medical Treatment Planning and Decisions Act, medical treatment is defined in 2 parts. So it must be for at least one of the purposes in this first column, and take one of the forms in the second column. So it might be diagnostic or preventative or restorative, or it might be to improve comfort and quality of life. It may take the form of treatment with physical or surgical therapy, treatment for mental illness, treatment with prescription pharmaceuticals or cannabis product, dental treatment or palliative care. And so treatment for mental illness and palliative care are new additions to the definition of medical treatment under the Medical Treatment Planning Decisions Act. Previously, they were not defined as medical treatment under the old legislation. So people can write an advanced care directive that relates to treatment for their mental illness and around palliative care. But it's very important to remember that people cannot actually refuse palliative care in an advanced care directive, and a medical treatment decision maker cannot refuse palliative care on someone else's behalf. Okay, so I'm going to go through the 3 steps of appoint a medical treatment decision maker, chat and communicate your wishes, and put it on paper. So, a patient with decision-making capacity has the right to consent to or refuse any treatment that is offered to them. But when someone does not have decision-making capacity, their medical treatment decision maker can consent to or refuse treatment on their behalf. And the medical treatment decision maker may be formally appointed, or they may be derived from the medical treatment decision maker hierarchy. So that image there is just an image of the template that is available through the Office of the Public Advocate and the Department of Health and Human Services for appointing a medical treatment decision maker. And this is the hierarchy. So being a hierarchy, it means you start at the top with number 1 and you work your way through the list until you find the first person who is reasonably willing, available and able to make decisions on behalf of the patient. So at the very top of the list is their appointed medical treatment decision maker. But if they don't have someone who's been formally appointed, the next question is to ask, do they have a guardian that's been appointed by VCAT to make medical decisions on their behalf? And if they don't have either of those first 2, which most people won't, so for most people we're looking at someone in category 3, which is the first of the following people who's in a close and continuing relationship with the patient. And close and continuing relationship is also something that was added to the legislation as part of the Medical Treatment Planning and Decisions Act, because the idea was to try and avoid a situation where, you know, the eldest child who has very little to do with the patient themselves and may, you know, live interstate, in the previous legislation was automatically the medical decision maker, whereas the youngest person, you know, might be the person who has the most to do with them and sees them on a regular basis and understands their medical treatment, etc. So the close and continuing relationship clause is quite important. So we start with spouse or domestic partner. So that's, you know, including same-sex partners, etc. If they don't have a spouse, do they have a primary carer? And that person is someone who's in a caring relationship, not someone who is employed to take care of that person. If they don't have a primary carer, do they have an adult child? If they don't have children, do they have parents? And if they don't have parents, do they have siblings? And if there's more than one child, parent or sibling, then you start with the eldest, and if the eldest is not reasonably willing, available and able to make decisions, you go to the second eldest and so on. Once you've exhausted that category, you move on to the next category. For children, so for people under the age of 18, their medical treatment decision maker is automatically their parent or guardian. That's one thing that children are unable to do, is appoint their own medical treatment decision maker. And the really important thing about the medical treatment decision maker role is that they are expected to make the decision that they reasonably believe is the decision that the person would have made for themselves. So the only way that you can make the decision that the person would have made for themselves is if you have a conversation about what the person would want. Choosing a medical treatment decision maker is not necessarily an easy thing to do. That person may or may not be a member of your family. They have to be over 18. They have to be willing and able. Obviously, they have to know what's important to you. You have to be able to trust them to respectfully represent you. It's important for them to be able to maintain their calm in a stressful situation. It's important for them to be someone who can be assertive and ask questions as necessary. They have to be available and they have to understand their role and responsibility. So it's quite a lot of things to think about in deciding who you might appoint. The witnessing requirements are fairly strict, so the appointment of a medical treatment decision maker must be in writing and in English. It has to include the person's full name, date of birth and address. It has to be signed in front of 2 witnesses, one of whom must be a registered medical practitioner or someone who can witness affidavits, such as a lawyer. And the appointed medical treatment decision maker, so the person who's being appointed to the role, also has to sign at the same time as those other people. So you all have to be together and sign it at the one time. So I guess these are just a few ways that you might think about starting a conversation with your patient about advanced care planning. So things like, do you mind if we now spend a few minutes talking about how you're going? I'm glad you mentioned that. I think it's an important time to talk about your overall health. It appears to me that we need to think about how things have changed. Even though you've had good news today, are you worried about... It's good, I think, to couch, because we want to make advanced care planning part of routine practice, it's good to say, you know, this is something I talk to all my patients about, because sometimes people have a misconception that we're only talking about end of life when we start talking about advanced care planning, and so they immediately jump to a conclusion that, you know, you think that there's some reason why they should be talking about this because they're imminently at risk of dying or something. So I think, you know, it's very important that we use language that's not confronting when we're having conversations with people about advanced care planning. So thinking about things like ensuring that you have enough time to have the conversation, being open to hearing what the person has to say. So if they raise issues, what makes you say that? Tell me more about how you're feeling. What is it that's worrying you? And for example, I was talking to someone recently about you know, patients coming to ask them about voluntary assisted dying. And the doctor was saying, you know, patients have always asked their doctors for help to end their life. It's just that now for a very small number of people, they'll be able to say yes. But really, this is not the end of a conversation. This is the start of a whole other conversation. So hearing someone when they come and ask for more information about something like voluntary assisted dying is an opportunity to then say, tell me more about, you know, how you're feeling, what it is that has prompted you to ask these questions, and try and explore, you know, why it is that the person feels the need to ask that. Because there's probably lots of information and lots of conversations that you can have around that topic that don't necessarily relate to the assisted dying process. So when people come and they say things like, you know, I've had enough, I'd be better off dead, I wouldn't want to go back to hospital, these are statements that if taken on face value, we might actually misinterpret the message that the patient is giving. So it's really important to listen to the person's values and preferences for future healthcare. Listen to why it is that certain situations or outcomes are unacceptable to them or considered overly burdensome. Acknowledge their emotions. So, you know, things like, it sounds like over the last few weeks you've had a really difficult time. eliciting meaning, tell me more about that. And, you know, just using silence, give the person time to elaborate and reflect. So the last step, and when I say last, it doesn't necessarily mean they're chronological. They don't actually have to happen in any particular order, but in fact, you know, chat and communicate probably should happen first, but it's really just that mnemonic about the three components. So putting it on paper involves writing an advanced care directive. So it's very important to remember that only someone with decision-making capacity can make an advanced care directive. You can't make an advanced care directive for somebody else who's already lost decision-making capacity. Only you can make an advanced care directive for yourself. An advanced care directive can be made by any person, including a child who has decision-making capacity in relation to each statement in their directive, as long as they understand the nature and effect of each of those statements. So they will still have a medical treatment decision maker, and that medical treatment decision maker, as I said before, must, as far as is reasonably possible, make the decision that they believe the patient would have made for themselves. So if there haven't been conversations directly about those issues, then the medical treatment decision maker is asked to reflect on the values, beliefs and preferences that that person has expressed in their life. So they might not be directly related to that particular situation, but you know, what were the things that were really important to them? So there actually are some resources that have been developed to guide medical treatment decision makers through that process when the person has already lost decision-making capacity. And they were developed originally at Northern Health, but they've been further developed by the Office of the Public Advocate, and they're now available from the Office of the Public Advocate website. They've only just been released. So that question's about who can actually make decisions. So there can only be one medical treatment decision maker at a time, whether they're appointed or derived from the hierarchy. The law says that there is only one person who can be the medical treatment decision maker at any one time. Now that doesn't mean that they can't have conversations within the family about, you know, how we understand, you know, this person would have, what they would have wanted in this situation, but only one person can actually be the medical treatment decision maker. So a person can make a legally binding advanced care directive in respect of current and future medical conditions, which may include an instructional directive. So you know how I was saying earlier that people with decision-making capacity have the right to consent to or refuse any treatment that's offered to them. The instructional directive takes effect as though the person was speaking directly to their health practitioner after that time when they have lost capacity. So it's really their future consent to or their future refusal of specific medical treatment, and it has the same legal standing as the consent or refusal of someone with decision-making capacity. So it takes effect in the same way. The values directive is more that statement of the person's values, beliefs and preferences, the things that are important to them, the things that make their life worth living, the things that they would want someone else to know about them if that person had to make a medical decision on their behalf. And the legislation says it must be considered by their medical treatment decision maker. And as I said, if there isn't a written document, then the medical treatment decision maker is asked to reflect on the values, beliefs and preferences that the person has expressed in their life. So you can complete either document or you can complete both. So the instructional directive is, you know, that very specific, I consent to the following treatment and I refuse the following treatment. The role of the registered medical practitioner in witnessing an advanced care directive is that they have to attest that the person has decision-making capacity for each of the statements in their advanced care directive, and that they understand the implications of each of those statements. So the registered medical practitioner has a role where they kind of have to help the person unpack anything that might not be clear. So, you know, making a statement like, I refuse CPR, it doesn't actually specify the circumstances. So does that mean the person doesn't want CPR under any circumstances, or are there circumstances in which they would accept resuscitation and not in others? So that's the kind of thing that the registered medical practitioner has to discuss with the patient in witnessing the document. And these are the kinds of things that someone might write in a values directive. So, you know, what matters most in life, family, independence, being able to do things that bring me joy, what worries me most about my future, that, you know, my condition is only going to get worse, it will never improve, and what are unacceptable outcomes of medical treatment. So, you know, if I'm not able to recognise my family or I'm not able to communicate with them, then I wouldn't want medical treatment that would prolong my life. Those are the kinds of things that someone would write in a values directive. Again, the witnessing requirements are that an advanced care directive must be in writing and in English, include the person's full name, date of birth and address, and be signed in front of 2 witnesses, one of whom must be a registered medical practitioner. So the witnesses sign a section in the advanced care directive that states that they believe that at the time of signing the document, the person did have decision-making capacity for each of the statements in their directive. And of course, the time to activate an advanced care directive is when the person has lost decision-making capacity and can no longer be directly involved in decision-making about their care. I actually think that advanced care directives kind of have a broader role than that. So I see them as being all wrapped up in health literacy and shared decision-making as well. So even if you have decision-making capacity, I think it's still a good idea to discuss the fact that you have an advanced care directive if you know, have a new condition diagnosed or something like that, so that you discuss with those new health practitioners that are involved in your care what your advanced care directive currently says and whether that will continue to meet your needs in your new circumstances. There's no expiry date on an advanced care directive. So the template that I showed you that is available from the Department of Health and Human Services, you can write an expiry date in it if you want to, but you don't have to. And if you don't, then the document continues until you revoke it or write a new one. So this is the flow chart that shows the steps that health practitioners need to go through in order to get consent for treatment when someone doesn't have decision-making capacity. Under the old legislation, we would immediately go to a proxy. You know, that would be your first step. If someone can't speak for themselves, you find someone who can speak on their behalf. But in fact, the first thing that health practitioners need to do under the new legislation is determine whether the person has an advanced care directive with a relevant instructional directive. So have they written down their wishes, their consent to or refusal of specific medical treatment that is relevant to the decision that needs to be made right now? And if they have done that, then the health practitioner must give effect to that advanced care directive. So if they don't have an advanced care directive, or they have one that is not relevant to the decision that needs to be made, then you go to the next step of saying, do they have a medical treatment decision maker? And as I said, that person can be appointed or derived from the hierarchy, and they all have the same power. So if they do have a medical treatment decision maker, that person can consent to or refuse treatment on behalf of the patient. And if they don't have either an advanced care directive or a medical treatment decision maker, then health practitioners need to take an additional step, which is to determine, is the treatment that I am offering significant treatment or routine treatment? And significant treatment is defined as any treatment that involves a significant degree of bodily intrusion, significant risk, or significant side effects, the potential for significant side effects or distress to the patient. So if it's significant treatment, they have to get consent from the Office of the Public Advocate to proceed, unless it's an emergency. Anything that doesn't meet the definition of significant treatment is by default routine treatment. So if it's routine treatment, then the health practitioner can administer that treatment without consent. So, you know, routine treatment would be things like routine antibiotics, routine analgesia, that kind of thing. Significant treatment, blood transfusions, surgery, you know, chemotherapy, things that carry a high risk for the patient. If they're a resident of or about to become a resident of a residential aged care facility, if they're at risk of losing their capacity to make decisions, so, you know, someone with a diagnosis of dementia, it's really important that while they still have the capacity to make those decisions for themselves, that they're given the opportunity to do so. If it's possible that there's going to be conflict within a family around medical decision making, that's a really good opportunity to discuss what the patient themselves actually wants. And advanced care directives are really important for people who don't have a medical treatment decision maker. So there are people in the world who don't have someone who could represent them at a time when they can't speak for themselves. And for those people, putting something in writing is a lot more important.